Thank you very much. It's a pleasure to be here. I want to thank the organizers for their kind invitation. In the next 10 minutes, I will try to show you why I feel that still in 2022, there is a good indication for some patients to proceed with the open Bankart repair. As you know, this technique was described and published at the beginning of the 19th century, and when I began my training as shoulder surgeon 30 years ago, it was perhaps the most popular technique and the most frequent technique. But after the advent of the arthroscopic surgery, it was a dramatic change, and the frequency of the open Bankart diminished dramatically. But as you know, things come and go. Some surgeons ask themselves if open technique was a procedure for dinosaur surgeons only, but today we have heard that what was called in the beginning of the 20th century the new gold standard for arthroscopic stabilization for glenohumeral instability now has less indications, and some groups, like in this paper from Switzerland in which Dr. Christian Gerber participates, do not recommend the arthroscopic Bankart for those cases with recurrent shoulder instability. So, where is the truth? Well, if we search in PubMed and we look for papers comparing open and arthroscopic treatment of meniscus tears, we will see that the last paper was published in 1989, and after that there was no more discussion about that. But still now, we had a lot of controversies and papers being published discussing if it is better to perform an open or an arthroscopic surgery to deal with glenohumeral instability. There are many papers that have been published. Perhaps this is one of the best according to their scientific design. In this paper, the population that was studied was very homogeneous, and there was a random selection of the cases in two groups. One group was operated by surgeons that were experts on open surgery, and other group operated by patients that were expert on arthroscopic surgery, and the rate of recurrence after surgery was almost 2 times in the isolated arthroscopic procedure comparing with the Bankart procedure. So open Bankart, at least in the literature, as we can see in this other search in PubMed, is a really current topic. We can see many papers that are discussing the indications and the showing pearls of the technique, because we must realize that many young surgeons have even never seen a Bankart repair, an open Bankart repair. I used the technique that was described by Dr. Rockwood in the 90s, and I think it has several advantages. It is an anatomical procedure. We do not pay with anatomy for stability. We can free the capsule, that we know is of paramount importance to manage the capsule, to give the capsule the tension that the capsule needs for a stable joint, as we can see here. We also have a clear view of the anterior labral lesion. Not only a view, we can decide if we want to perform a transosseous repair or use anchors. The bleeding of the neck of the scapula liberate growing factors that will help to the healing of the capsule to the humeral, to the scapular neck and the glenoid rim. We can perform a precise and robust imbrication of the capsulolabral tissue. We create two different flaps, a medial flap and a lateral flap, that we give us the chance to close the capsule and also to act in the inferior pouch. There are some in vitro studies that have shown that this is a very effective procedure. As I said, we can create a double thickness of repair by overlapping the capsule. So we are not just puckering the capsule, we are cutting it, and we are generating again a healing process, and also a double layer of capsule in the anterior-inferior area of the joint. There was a very smart question this morning about the inferior pouch closure. I think that this is a very important step in this surgery, and as we are taking the medial flap laterally encephalic and the lateral flap medially encephalic, we really make a very strong closure of the inferior pouch. If you put your finger in the anatomical neck of the humerus and pull the stitches, you feel the strength of this closure. Also, we have a better control of the rotator interval, and it has been demonstrated by Provencher that it is very effective. We have an arm that is free, so we can position the arm at any moment of the surgery in different options to make easier our surgery. And if we compare this procedure with the reconstructive procedures, it has a low complication rate, so it is advisable on that way also. So, which is the indication for this type of technique? Well, it has been demonstrated that young patients have an increased risk of recurrence after arthroscopic repair, and especially collision athletes. In my case, rugby is very popular in my country, and we need to treat many young patients with first or second dislocation that want to go back to rugby. The increased risk in collision athletes with the arthroscopic Bankart has been demonstrated. We consider that for patients in the gray zone is a good option. Our friend Giovanni Di Giacomo have also included this option in his algorithm. Patients with multiple dislocations have better chances with open surgery. Patients with multidirectional instability, we have said that we have a very good control of the capsule and that we can close in a very effective way the rotator interval. So for these patients, we have very good results with an open capsular shift. And for revision surgery, in those cases that underwent a good arthroscopic procedure, but with good results. This has also been published by several authors. So we think that we do not have a gold standard patient, so there are not gold standard techniques. We need to adapt to every patient. In our toolbox, we need to have different options. We must always consider that rehab for some specific types of instabilities is a good option. Of course, arthroscopic surgery that has expanded its indication with the new techniques that are adding more stability and more solid construction, and of course with bone defects there is no other option than a reconstructive procedure, but in between we have patients that could have a very good result with an open repair. So following what one of the heroes of the arthroscopic surgery, Dr. Bob Arciero, said, don't forget the open Bankart, look at the evidence. There are designs that besides time that are still current, and we should consider them. And finally, I want to thank the chance to be here and inspiring this type of courses. We will launch this year the Patagonia Shoulder and Elbow Meeting. Thank you very much.